Yeah, I see this as well. Okay, now we're ready.
Done that last night, we got.
Now we're ready.
All right. Welcome to the June 12, 2025 meeting of the Health and Environment Committee. My name is Rupal Tikad and I am the chair of the committee. Tonight, we are joined by Assistant District Manager Brendan Blood. This meeting is called to order at
6:35.
6:35 p.m. As a reminder, New York State law requires all committee members who are not able to attend the meeting in person to have their cameras on and their first and last names displayed from the time the meeting is called to order until the meeting is adjourned. Members of the public who are attending virtually, you can raise any questions or comments that you have through the Q&A feature of Zoom. Members of the public who are here in person, is there anyone here in person? I'm gonna skip that part then. We need a volunteer to take minutes tonight. If you're able to take minutes, please let us know.
Minutes.
You, all right, so Gloria has very kindly agreed to take the minutes. We will now take attendance by roll call. Brendan will conduct the roll call.
Committee members, I will call your name. When your name is called, please say present. I will announce if there is quorum. Marty Barrett won't be with us tonight. Elvie Barroso also won't be with us tonight. Barack Friedman won't be with us tonight. Gloria Haig,
Present.
Rupal Tikad,
Present.
Kevin O'Keefe,
Present.
Miriam Rowe,
Present.
and Mubin Siddiqui.
Present.
We have a quorum.
Excellent. The agenda for tonight's meeting was distributed ahead of time by the board office and is reflected on the screen before you. If there is no objection, we will adopt the agenda. Members of the committee, if you object to adopting the agenda, please raise your hand. See no objections, we're gonna adopt the meetings. The minutes are, adopt the agenda. The minutes from the May 8th meeting were distributed ahead of time by board office. If there's no objection, we will adopt the minutes as drafted. Members of the committee, if you object to adopting the minutes, please raise your hand. No one is objecting, so we will be adopting the meeting. They will soon be available on the CP6 website. In order to conduct an efficient meeting, let's observe a few ground rules. No one may speak until granted the floor. Committee members who are here in person, if you have a question, committee business, or wish to make a motion, please raise your hand and I will identify you so you can speak. Committee members unable to attend in person, if you have a question about the committee business, you may raise your hand through Zoom and I will identify you so you can speak. All committee members, it is extremely important that let's not talk over each other. It's easier to understand everybody when people are listening to it on Zoom or later on watching the video. The chat function for the committee members present via Zoom should not be used for committee business or questions about agenda topics. All such remarks should be made on the record by raising your hand through Zoom. Chat should only be used to alert us to any technical difficulties you are having or to state in writing information like an email address that was already stated out loud on the record during the meeting. All right, so tonight's agenda, the first item on the list is is Mount Sinai, presentation by Mount Sinai regarding the health services available to the community in the wake of Beth Israel Hospital's closure about a month ago. So we have,
You want me to introduce everybody?
yes, go ahead and introduce you.
I'm Brad Korn. I'm the Senior Director of Government and Community Affairs. I've worked with Community Board 6 quite often and happy to be here tonight. I'm joined by Kelly Casano, who is our Executive Vice President and Chief Ambulatory Care Officer for the health system. And she's also the Chief Executive Officer of our Mount Sinai Faculty Practice Program. I'm also joined by Paul Zucker, who is the Executive Vice President and Chief Ambulatory Care and Chief of Ambulatory Care. Paul is in charge of our Union Square facility, 10 Union Square East, and he also has oversight on the new urgent care center at New York Ioneer. So we thought we were the most apropos to come tonight to discuss. We were sent a list of questions for the board. We thought initially the best way to move forward is to go through the questions. And then if there are additional questions, you know, like if you have something about a busway or something like that, we can help you. We could, you know, we could answer those too maybe, but, you know, so we're gonna go through the questions if you don't mind. We just think that's the most efficient way to handle it. So I'm gonna throw the questions up if you don't mind, and you guys,
That'd be great.
you pick a person to answer. I just had him and I lost him.
It's like Jeopardy.
Yeah, I know. In the form
I,
of,
I
okay,
have to say, by the way, this is my first community board meeting, by the way, this is my first community board meeting, so this is kind of exciting. And this is community board 6, that this map represents 6, okay.
Yep.
I live in 10003, so not far, some of this may comprise 100. Anyway, thank you.
Kelly and I have been to other community board meetings. So the first thing we're asked is what kind of patients are we currently seeing at the urgent care center?
Yeah.
And if you can provide some
have
demographic
some
information.
stats. That's all. I should probably defer to the doctor here.
I'm gonna do I have the same list. So, I'm not sure exactly whether you mean demographics of the individuals, but we thought we would first start with the clinical complaints. That was one of the biggest concerns folks had about the ED and sort of making sure that we were addressing most of the things that were at the time of closure, literally walking into the emergency department. And so we have seen, sort of in order of volume. First is acute pharyngitis or a sore throat. We see a lot of folks with, just painful or, urinary frequencies, so typical UTI symptoms, rash, chest pain. We saw about, 45 patients so far, so about 4% of the total. Other specified disorders of eyes. So, could be somebody had pink eye, could be somebody thinks they have something caught in the eye, but a little bit of the eye. And we think that's historic from this having once been the site of an eye emergency walk-in clinic. Cough, fever, again, UTIs, ear pain, more specifically the left ear, and changes in vision. And so that sort of makes up the top few diagnoses, and then, dizziness and nausea vomiting. Probably nausea vomiting is very seasonal, and that is less than 2% of the folks that we're seeing.
And do you have any age information, like overall, is it more older people, is it more younger people or kids,
Yeah.
Yeah, we do have the breakdown.
Slide deck. So about, we broke this down into less than 18, 18 to 29, 30 to 39, 40 to 65, and then over 65. The largest group are those between the ages of 18 and 29 at 37%. The next is those aged 40 to 65 at 27%, then 30 to 39 at 18%, 65 and older about 12%, and less than 18, 7%.
So relatively on the younger side, most of the people are relatively on the younger
I
age.
think you probably see that at most urgent care centers, that age, they don't generally have doctors yet. They haven't started doing it, so if they're not feeling well, they run into an urgent care center.
And when they come in for these emergencies, do you kind of help them get access to like more care, like as in, hey, by the way, you should be doing this regularly, annual physicals, do you kind of guide them so that they do end up getting care regularly, so they don't end up in, preventative or?
Yes, we're primary care physicians, so I am all about redirecting people to continuity-based care. I will tell you, we've been at this since urgent care sort of got their foothold, a decade ago. This age group is really resistant to having primary care docs, right? They want to be served, seen when they want to be seen, and urgent care fills that gap for many of them. But we have the ability for patients to be directed to appointments when they leave the urgent care center. We make available to them, we have a very large facility, as you know, at Union Square, where we have lots of primary care. So we really do try to encourage people to establish physicians. We like urgent care, but we really want you to have those relationships ongoing.
And do you have any insurance information in the sense that all these people using, are they Medicaid, Medicare, private insurance?
They have the breakdown, but we take everybody.
Mhm.
We take uninsured, we take Medicaid, we take Medicare. And obviously for an urgent care center, the one at Union Square also takes Medicaid, but it's not that common for an urgent care center. But that was part of what we
Yeah.
agreed to do for patients. So we take,
Yeah, we have.
private, Medicare, Medicaid, and uninsured.
We are surprised at the demographic of the patients that we're ultimately seeing. We thought that it actually would reflect the ED a little bit more. That was FBI. The average, by percent is 63% commercial pay. We're seeing about 3% Medicare, 7% Medicare managed care, and then about 18% Medicaid, and about 9% on the self-pay side. So, it's a healthy payer mix, but, a lot more commercial-based patients, which I think is reflective of that age group too.
And then when we follow, what's currently being treated, how many patients on an average are being transferred to, other facilities? Because they're coming to urgent care, but they really need emergent care. They need emergency care.
Yeah, across the board, it's less than 7%, the highest being chest pain, which is at 6% of total patients being seen. Abdominal pain is probably about 5%, and then shortness of breath, other stomach pain, and neurology related are around 3 and 4%.
But our numbers also are consistent with what most urgent care centers see. A lot of people do go to urgent care centers and then need to be transferred out. So it's not anything.
Yeah, and these are small numbers of the total.
And where are they being transferred to? Like, are they being transferred to another Beth Israel or Mount Sinai
yeah.
facility? Or are they being transferred to like?
It's a 911 call, correct?
That's correct. So when we call 911 determines the most appropriate place to send them. But we do have an internal Mount Sinai transfer team, and so, we often utilize that as opposed to 911, and we can direct them to, for example, Mount Sinai West, which is 59th Street.
So something that's truly not life threatening, we would prefer to, continue to care for those patients. I'm sure you're aware that the FDNY, right, has changed their the way they dispatch, and so it used to be that patients could request a specific emergency room as long as it wasn't way out of the way. That is no longer the case, and they are going to be taken to the nearest. So in that case, this would probably be NYU or Bellevue.
Now, you asked a question about stroke and cardiac events. We are not receiving ambulances. 911 system knows not to bring, we are an urgent care center, not an emergency room. So that's not different than any other urgent care center, and the walk-ins are consistent also with urgent care centers.
Kevin?
I was just saying, for a major event, where it's all hands on deck, I would imagine that you would, if it's some catastrophic event where all hospitals need to be on alert, is that?
Seeing if a 9/11 type of situation occurred again, because even COVID wasn't that type of thing.
Like a September 11th.
Yeah, that's what I mean, yeah.
Yeah.
Are you equipped to handle that type of emergency if you're called into duty because of the number of people that may be impacted?
We would likely mobilize teams to central areas that are proximate within the community so that they have generators, they're equipped to be run in an emergency situation. Union Square is the one Paul leads those efforts. So we would, again, bring that more central where you've got ORs and capacity to deal with real catastrophic. So.
Thank you.
The next question is a sort of open-ended, what do we consider to be a successful urgent care center? So I'm gonna let the doctor and the administrator take that one.
Sure, let's see. So I think we've got that here. So successful urgent care. So we look at access, efficiency, we measure patient satisfaction. We're going to be starting to look at some clinical quality metrics, antibiotic stewardship, and
I think the most important thing, right, is being there when patients need us, right? And so access, whether it's the urgent care or even in our practices, this has been a priority of ours. We have become obsessed with timely access to care, and really understanding what that means for all of our patients, regardless of location. But, patients who engage care at urgent care usually want that as a priority, right? Again, when they want, how they want it. And so we focus on that, but once they get there, we have to make sure they're getting high quality care and that they have a good experience. And so those have sort of been the things that we have focused most on. Now that we have sort of a decent N in terms of patients, number of patients, we can now start to look at the quality in a way where we want to make sure we're, performing at our highest level.
So besides that, is there
I
like,
think Sandy is.
oh, sorry,
Sorry, I
Sandy.
did have a question.
Yeah, sorry.
I'm wondering, you're 24/7, which is different than other urgent cares.
centers, has that changed what you see, do you think? Is that?
No, we're sort of seeing the same things throughout the 24-hour time span. I think that's when we're seeing that age group the most.
The younger.
Yeah,
But the least utilization is at
Is
this
the-
point from 11 p.m. to 8 a.m., right?
That's correct,
That
yeah.
We're not seeing a large overnight, lot of people showing up overnight.
What would be the percentage of the overnight compared to the whole?
I think it's under 10%.
Have that here. Second. So the percentage of patient arrivals after midnight in April, we opened up in April 8th, it's 21% of our total. In May, it went down to 18%. For the first third of June, it's down to 15%.
Can you give a whole number, like 10% of what?
Oh, sure. So we're seeing, so in April, we saw 755
Okay.
patients total. We average about 33 a day.
Okay,
Yeah, so in May, we were up to 975.
okay, thanks.
Yeah, sure.
So what was the lowest time you said?
From 11 p.m. to 7 or 8 a.m. is,
The slide that I have, it's more like 1 AM to 7 AM. So,
okay.
Right, so we look at time slots, you know, in greater detail than just after midnight but 1 AM to 7 AM, that is our absolute lowest time. So Brad mentioned after midnight, but give or take, right? Between 1 and 7 in May, we're averaging only a half a patient an hour. We don't split them in half, of course.
Well, then we have to send them to an emergency
Yeah.
room to get a half a patient, yeah.
That's because most people don't know an urgent care is open 24/7. Are you the only urgent care that's 24/7?
that we know of, I think probably most people think of like the Healthplex, the Northwell Healthplex, they know that has hours. You know, it's a great question, and I think it's probably more related to, most people are not out at 2 a.m, and if they are, they are. Meaning seeking healthcare, if they are feeling that ill, most people are heading to emergency room. This goes back, many years ago, we had an urgent care, when
23rd and 7th.
23rd, yeah. and
We had a
7th.
24/7 office and eventually the overnight utilization was next to nothing.
Because I know one of the things about the urgent care is that it's meant to replace to a certain extent the emergency room that is at the hospital. And it seems like we need more advertising or somehow getting people to actually utilize.
We have a pretty robust advertising. We did an initial big campaign. We have a pretty good digital presence, online presence. In fact, I think it's somewhere in the deck, keep me honest here. The most common way people are finding us is a Google search, which sadly is how most people are finding out healthcare today. Yeah, it's, people know how to find us. My guess is that if they really are, we were concerned initially people wouldn't be able to differentiate what belongs in urgent care, but what belongs in ED. And it seems like folks have figured that out based on what we're seeing coming in.
so as far as the marketing and everything goes, are there any posters at any NYCHA or Section 8 housing? Because you said, I think 63% commercially insured and only 18% Medicaid, but that's not what BI used to see, right? Like that doesn't match
Yep.
the hospital
It
data.
closely reflects what we see, closely, not specifically, though, in our urgent care at Union Square. And typically in urgent cares across the city.
Right, but the hospital that closed, that's not the demographic, or that's not what it was. So, I know this is a conjecture, but all the patients that were Medicaid that were being seen more at BI, where are they going? Is it that they don't know that the 14th Street Center exists for them to go? Or are they just not seeking care? Or are they like, is there anything?
Not sure, we.
When it
did
may,
the original.
part of it may be that, they're still utilizing an emergency room. They may be going to NYU or Bellevue, or if they're a little further down, they might be going to Presby's. So it may be that their care, in their mind, the care that they need, they think is emergent, not urgent. So we don't know that we're we have done targeted mailings and we've done to people who were patients. So we did mailing to people and that would have gone to public housing residents. We've done, I know that a lot of our elected officials have put it into their blast emails and we advertise in newspapers as well.
The majority of our patients are coming from 10003 and 10009. So it's the local community.
So 10009, if you're coming, let's say from Stuytown, lower end, that's 1009. Physically, if you go to the closed building, I would imagine there's physical signage there that will direct them to.
There's two things there. There's physical signage and there's still an ambulance sitting there that if somebody shows up and is actually having an emergency, we take them in that ambulance to an emergency room.
Security is still posted outside, they do. Yeah.
I believe so, yeah. I just-
On all entrances that were
With the
normally,
emergency department.
or just the emergency.
And,
Okay. No, I was just gonna say that, say about the direction, so it'll just say that there'll be a phone number and it'll direct them to where they need to go. Oh, that's what I was gonna ask too, the ADA compliance, how does the ADA compliance compare to the closed building? Is thorough
Probably better.
Yeah, it's gonna be-
Possibly, yeah.
from elevators to
Oh, yeah.
entrance ramps
It's
to?
it's first floor. It's on the first floor entrance of the, it's the, you go in the main entrance of New York Ioneer, so they're fully compliant, yeah.
and posters at the Night Shine Section 8 housing, have you put up any posters or
I have
any?
to go
sign-
back and check. I know that it was originally on our list of requests, but we, I think we definitely did the mailing.
Okay.
But we can go back and check and
Yeah,
see,
Can you please
Yeah.
get back to us on that?
Sure.
You know, the metrics for success, like we understand that this urgent care one, it may not stay open if it's not successful. Is that the case?
successful, I think it would just be what, if the community continues to need us and at what time of day, we'll continue to be there.
So 21% utilizing app from 1 to 8, is that?
Well, that's dropping, so we, obviously. There's a lot of things we still.
15%, but
Yeah.
we just opened,
Yeah.
right? So
Yeah.
it's a little bit too early to judge.
And I guess that's what's more like the question about the metrics that we were just wondering what is a successful, is there a percentage you're looking for, is there?
Let me say this. If you look, we know this center is gonna lose money. We did not build it to make money. One of the things is our whole plan is we lose much less money than we used to. So it doesn't have to be a financial success. We are looking for utilization.
Yeah.
That's success. Consistent utilization would be success.
And some, sorry, go ahead.
If you look at the life cycle of an urgent care center, you're really open such a short time.
Right.
And it's gonna take time for people to know you're there and time to really get real metrics. So is there a time frame of which you're kind of holding tight with like the hours and what you're serving to find out really what because 2 months is not.
We have no.
We have-
Horizon to make a
Yeah,
change.
there's no, right. In
Yeah.
fact, we're enhancing services shortly, and that goes to one of the questions, because we're putting a CT scan in there, which we expect will be actually installed in July, but then the state has to do an inspection. So we don't really expect to be able to start using it until sometime in late August, probably, with approvals and such.
Unless, of course, you have any pull at the state. Get that up and running sooner, everybody, we'd be happy to take the help.
So I know part of the agreement with the DOH was the 3 months of 24/7, but as you just mentioned, the CT scan won't be there.
Right, no,
Until August.
we understand all that. We are,
So,
That's helpful.
Just on the data collection, are you getting patient reviews from the start so that you really do have a good handle on what the concerns are?
Yeah, we administer Press Ganey surveys, which are traditionally the industry benchmark. So we do have preliminary data. I can share it. We just started a second survey tool called Q Reviews, where we actually text the patient an hour after the visit to get feedback. But so far in these broad categories, we've had 51 responses so far. So while we may send them to everyone, not everybody responds or responds in a timely manner. giving us the highest mark possible on each score, which is typically a scale of 1 to 5. 86% of us on an overall experience, that's literally the category, have given us that top box score. How well the care provider listened to you, 9 out of 10. So we have a 90%. Likelihood of recommending the practice, 82.3. Staff working together to care for you, 88.2. And access overall is 80%.
That's helpful.
Yeah.
Are there things like wait time and any, those type of concerns, will they bubble up into those data collection?
Yeah, so wait times roll up into the access measure.
Okay.
But that's one of our quality measures. So we're looking at time to arrival and time between arrival and when we discharge you. So I don't have that data with me, perhaps next time.
But are you satisfied with that wait time where you need to be, or?
So far, I mean, with, 86 out of 100, 90 out of 100 people giving us the absolute best score, we'll take that. I mean, that's terrific, and we're really happy about it. Dr. Asano mentioned, we're surprised at how many people are utilizing the urgent care, just the first 3 months of being open. I think that's a testament to the experience.
And one of the other reasons we put, so there's 2 surveys that, the gold standard for patient surveys is the Press Ganey, as Paul mentioned. The slight downside to that, it comes a little bit later than when you had a visit. We are fans of what we call the Q reviews, which was what Paul mentioned, and that comes within an hour or 2 of you being there. We find that to be incredibly actionable data, right? Because if something really went wrong then, we're looking at it in almost real time. The managers check these throughout the day, or at least by end of day, so we can do an outreach to folks and really understand what went wrong, and then be more actionable on that feedback. So both are really important, but we find the Q review data, especially in early practices where, things are not always it's not always the well-oiled machine you want it to be in those first few days, months. So we find the Q is incredibly helpful when we open new sites.
John, I have a question, but I'll let John go first. He's been debating for some time. No.
I have 2 questions. First of all, is it common for a urgent care center to have a CT scan?
No.
No, I didn't
Yeah,
think
that's
so.
what happened.
Secondly, I think about Sinai as having fantastic physicians. Are the same physicians who are at your hospital staffing the urgent care?
Yeah, there are
Yeah,
ED
wow.
docs.
They're ED docs.
We're rotating our existing ER physicians through the urgent care center, which is what we do at Union Square as well.
So you have physicians there who, I probably have a question, whose the profile is very good. I won't
They're
test it.
all board certified, yeah, emergency room physician.
And that's atypical for urgent cares.
Right.
Yeah.
Let's try that.
Also, I see that Larry Shire, who's a member, also has a question.
Oh, yeah, actually, can we get you let
No,
me?
I can wait. It's not that hard. All right.
Okay, Larry, you should be allowed to speak now. Larry?
Unmute. Am I unmuted?
Yes, you are.
Okay. I had an experience yesterday which really focused me on the question of what an urgent care does and what it doesn't do. And I was on a tele call following up with an emergency room visit beginning of the month. And while I was on the call, the doctor I was speaking to said that something I was new, I described to him, required me to drop everything I was doing and get to the closest emergency room. Immediately, I thought of Beth Israel Medical Center, where I'd gone to in the past, which is the closest to Stuyvesant Town. And unfortunately, it's not there anymore. And so I ended up going to NYU, and they rushed me into a CT machine even before they caught up with me with a bracelet. So I was very fortunate that it wasn't a stroke, which I guess is what they were concerned about. But if I had gone into the facility at 2nd Avenue with the things that I was discussing on the telephone, which were a follow-up of my earlier emergency room visit. You mentioned that you would take somebody by ambulance. How would that be arranged?
Sure. So if you arrived at our urgent care, you would be triaged by the physician. If
No,
they
no,
det-
no, no. Let's say in the middle of my conversation
Mhm.
about a musculoskeletal thing. I on the first, I fainted and smashed my face, and may have broken some bones in my shoulder and chest, but it wasn't described on the X-rays, and I was following up. I wanted to ask about that as well. And in the middle of the conversation, I felt numb in the face. And if I'm talking to one of your people at the urgent care, how would that scenario likely play out? Because this is really what happened to me, and it might have been, my choice of where to, get some kind of follow-up because it's very close to where I live. Can you suggest a scenario?
We would transport you again. In that case, we wouldn't wait for one of our internal ambulances to transport you. We would call it a 911 call. And so you would be, we would be stabilizing and then a 911 ambulance would arrive.
Okay, and so. Okay, that I guess that's the answer to the question. I had another question about really because I'm sort of from the old school. Urgent care is a new concept. When I was younger, there was something that frequently was available at workplaces, for example, called an infirmary. And how does this compare to what is offered in one of those types of places, a medical clinic such as that? And what more does this offer? I couldn't quite get the answer to the question of whether you use whether you have CT machines and what other maybe more sophisticated equipment than an X-ray machine.
Yeah, so, the question was raised earlier, are CT scans typical in urgent care centers, and they are not. We will put one, as we've described in this urgent care. We have X-rays, so typical X-rays, more bony issues or chest X-rays to look at infection. We do have what we call bedside ultrasound, so it's an ultrasound machine that can do a very specific ultrasound if someone's looking for a kidney stone or an ovarian cyst, let's say. So, again, that is not typical of an urgent care. Your average urgent care center will typically have X-rays. But
Right.
we added the ultrasound and the CT scan.
Right. Well, let me ask you about the ultrasound because I've had a few of those in the last week. I had one on the carotid artery. I had one on the on the chest cavity. Looking at the blood vessels and the flow of the blood. That's more sophisticated than what you do.
It is. I mean, we would consider those diagnostic ultrasounds, and what we're looking for really in the urgent care is something just called like a screening, right? And so we just want to make a quick assessment of a very specific body part to answer a very specific question. Your carotid, doctor, we call that ultrasound of the neck and the blood flow, and then likely an echocardiogram, which is an ultrasound of the heart.
Right.
If you were in need of that level of imaging at the urgent care, we would be considering you much more acute and you would belong in an emergency room.
I gotcha. Okay. And as far as orthopedic issues go, you have the X-rays, and what if it's like a torn ligament or something like that? You don't have the imaging that would be able to detect that. Like somebody fell off a bicycle, but they didn't break any bones, and this happened to me. But I had some ligaments torn in my wrist.
Yeah.
How much could you discern?
Yeah, you would likely be referred for an MRI. I will say even in an emergency department, a full thickness emergency department, if you had it, suspicious for something like a torn ligament, you still would not get an MRI in an emergency department. MRIs are very, very limited in the acute setting, typically used for things like stroke, or
Right.
some rare concerns. So usually for even falls, fractures, outside of something that's found on an X-ray, even in an emergency room, you'd be referred for an outpatient MRI.
So you would basically be concerned in stabilizing a broken bone, putting a cast on it or a splint?
Absolutely. Yep, and one of the things we try to do for the folks that are being seen, I mean, if they need a specialist, we do work to coordinate those appointments on site in the same building, actually, just across the hallway is a primary care practice. And then over at Union Square, as many of you know, we have 30 medical and surgical specialties, and we do what we can to make sure that folks are at least having follow-up there, especially if we're concerned that somebody has a fracture or torn ligament, something that really needs acute care. We're plugging those patients into follow-up care.
Right, and somebody mentioned whether the wait time was acceptable or not. Do you have any kind of a sense of what times of day are the busiest and what are the easiest to get seen by somebody?
Larry, we did go through this documentation earlier. I think
We can send you,
Publish that
we
out.
can forward, the date, the
Yeah.
spread, the data they sent us.
Okay, that'd be great. I have no further questions.
So maybe that's a response to what I'm going to ask. So, Sandy had asked you about the success of the urgent care that you've opened, and you were saying 33 patients per day roughly. That sounds pretty robust to me, but I just wondered, since you benchmark against all the urgent centers, what is considered like a healthy daily visitation by patients?
The 33 is similar to what we see at Union Square. Our Mount Sinai busiest urgent care, 91st Street is about 45
That's
to
right.
50 patients a day. But some in the community can see upwards of 100. We built the capacity at New York Pioneer Urgent Care to meet the demand of walk-ins that we were seeing at Beth Israel. We can see many more patients than what we're seeing.
So the ones that are seeing upwards of 100, are they 24/7 like you guys are? Or just a regular urgent care?
We think we're the only 24/7 urgent care right now.
Yeah, when you look at urgent care, probably City MD is the most known
yes.
to everybody. And even they, when you look at their volumes, it really depends on the neighborhood,
Location.
where they are and what
Look, I live
else
in
is.
Forest Hills. There are 6 different urgent care centers within 2 blocks. Northwell has, City MD has, there's one
Yeah,
for
there's-
pediatric.
Even on 14th Street,
Yeah.
they line 14th Street.
Yes.
And
Thank you.
Yeah.
And I know one of the questions that we've gotten is, like, ZIP 1002, where are those people going, who used to go to Beth Israel?
We're not tracking individual patients. We would have no way of knowing that they're utilizing services. We don't have access to that type of information. I think Brad's point is well taken, that there may just be a subset of population of the patients who feel that they still need emergency room care. And they can be going to any one of the other emergency rooms down.
And forgive me for asking this, I should know better. 1002 is where? Give me a
It's
better
basically
idea.
the Lower East Side and down to the tip of the island.
So that there is, New York Presbyterian does have one down at the tip of the island. And it could be, if they think they need an emergency room, they might be going to the Healthplex also.
It's, excuse me, south of East House.
Okay,
Yeah, I also mentioned that our highest utilized was 10003, followed by 9.
Mhm.
The third highest is 10002.
okay.
Okay.
All right.
Some people have.
So some people they're just not the number one.
And maybe that once they spread the word, these things.
Yeah.
And, Mark Henney used to had a question, his hand up. Mark, do you still have a question? Do you still wanna ask your question?
They answered my question already. I was gonna ask the comparison of Union Square activities, the urgent care center there versus the one at Pioneer, but they answered the question. Thank you.
And Andrea Lyman?
I put a question into the Q&A function. Are you going to get to those, or I can ask it now?
You say you take uninsured, what is the charge? Is a payment plan offered? Is cost waived under New York State requirements for charity care? Yes, cost is waived if people qualify, and yes, we offer payment plans and financial assistance and, right? But first things first, we take care of the patient.
And we will.
What
help try to
happens
qualify the
at
person.
What happens at the entrance? Do they have to provide a
No.
credit card?
No,
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 not at all.
not at all. But we will also
Thank you.
try, if they qualify for Medicaid, to, to have our financial counselors certify and get them Medicaid if they haven't done so.
Also atypical of urgent cares.
Right.
Thank you.
And you guys also asked about the hospital at home program. The 16th Street campus has not changed how the hospital at home program is being operated. Right now, it's currently seeing approximately 150 patients. They're hoping by next year to ramp that up to closer to 200, and then in 2027, make a bigger leap to get to closer to 400. And about 15% come from the Lower East Side and always have come from the Lower East Side. That won't change. They can still access that. That the fact that the 16th Street campus is closed won't change how that's operating.
And are you actively promoting that program, or you're not at the moment promoting it?
There's some very strict guidelines on how patients can be approached about going to hospital at home. The activity has to happen through the emergency department. And so it's very limited as to who, and then the criteria to actually, to sort of qualify for a hospital at home stay.
And then, let's see, what other questions have we not gone through? Oh, the flyers. The flyers that, at least the original ones we've seen, did not include any information about insurance, as in like that you do accept uninsured
The newer
Medicaid,
ones being
Medicare.
printed have that. We're not gonna list every insurance we take,
No,
because
but-
otherwise that would be the whole flyer, but we will list that we take Medicaid and uninsured.
Okay.
I
Yeah.
think they have QR codes on them too.
Right,
Which takes
but-
them to a page and
Right.
you get all of them.
Right, I know it is listed on your
Yeah,
website, we
On
can
the-
see that on the
Yeah.
flyer itself, the ones that we've seen did not have that, yeah. And then, let's see. The last question, would you provide an update on the impact and actions taken regarding the loss of MSBI's comprehensive psychiatric emergency program, the CPAP program?
So our program at Rivington does not have a CPAP, but we are working closely with Bellevue CPAP, and we're having them send us direct admissions. And there's a daily and a weekly meeting between our leaders and their leaders for that. To take up some more of the slack, especially for the people from not that you care as much about Chelsea and that for the people who came to Beth Israel, they're expanding the Mount Sinai West CPAP and the one at Mount Sinai Hospital as well. But we're working closely with Bellevue to make sure that everything's smooth, and if they're overwhelmed, we have capacity to take people.
And speaking of Bellevue.
We're online with our money and payments, everything's up to date, everything, we're all in queue. Any specific questions dealing with their operations and stuff that they'd have to answer, but we're all up to date with our payments and such that we're supposed to be doing.
All right. And one last question, I'm not sure if you'll be able to answer this or not, but I'll ask anyway. So what determines if an ambulance goes to Bellevue or NYU or somewhere else?
FDNY, right?
That the NY makes that determination?
And I think Paul brought this up before. It used to be, there was a little more leeway for a patient to say, but the new fire commissioner basically has put down now, we're taking you where we're gonna take you. in a- Closest one.
The goal is to overall decrease the response times
Right.
for all ambulances, and so to do that, they just take another.
So
Now-
what happens if your physician is, my physician's with Mount Sinai?
Thank you.
32 years with him, but he's getting very old, so I don't know what's.
We can get you a new
Let
one.
us know.
I don't know what fashion urgent, I don't get the, I mean, I don't do the urgent, anyway. I might have to, right? What, so you say you
By
sent
the way,
someone?
where do you live?
Midtown, like by the UN.
Oh, I was gonna say, because we do have, if you were Startown, we have a practice in Startown too.
34th and-
Right, we have 34th.
Okay, so I was just with the new system up, so if I fall in front of Bellevue, clearly they're taking me to Bellevue.
Yeah.
But my doctor doesn't have visiting rights at Bellevue. How does that work?
You know, communication between the physicians. There is something in most EMRs called Care Everywhere. Epic is one of the biggest EMRs. And we can see into other health systems records. But I will say that this has come up in terms of like, you know, having the ability, you know, we worry about very complex patients, like transplant patients being able to come back to the hospital. And I think that, you know, the FDNY has been very attentive at hearing the health system's concerns around patients' continuity. But until that gets figured out, or until anything else, it really is communication.
But you also, and correct me if I'm wrong, once the emergency is treated, you can ask for a transfer.
You sure?
You can ask for a transfer to Mount Sinai, and we have a patient transfer
Yeah.
I
department.
mean, I think
that
it's
work-
great to have
No,
quick time.
No,
to
no,
an
but that's what I'm
emergency,
saying.
But I think for old people like me.
No, but what I'm saying
These
is,
doctors for a long time.
but if, let's say, whatever the emergency was, they handled the emergency, but let's say you needed follow-up surgery,
Then you
God forbid.
could-
You can ask, if they want to, you can ask for a transfer, and we have a whole
Yeah,
transfer
it's a great
department that can bring you to Mount Sinai.
How long has that system been in place where you have to just go to the closest or they
Very
decide?
recently, within
It's
the last,
recent.
like in the last 2 months, maybe 3
Oh.
months the most.
Oh,
It's
we'll
the
see
new-
how
it's,
that goes then, huh?
Well, I mean, that was always in an emergency. You weren't kind of supposed to go to the closest anyway, but yeah, this is reasonably new.
Interesting.
And by the way, we're not going away. We're not, you know, if you have more questions or whatever, we're here, you know. I'm on with Brendan and Jesus all the time, asking questions, you know, having questions asked.
We had a
So-
beautiful presentation by Bellevue last night at our meeting. They did say they're getting quite busy and we're gonna have to figure out, I mean, I'm like thinking manpower, person power, doctor power.
Well, but part of the money we're giving is for them to expand some of the capacity to take care of that load.
Because I knew that was mentioned.
Are
that they
you
were getting-
concerned like they are with the reconciliation bill and?
We're terrified with, as a government and community affairs person, we are extremely terrified.
Could you articulate on what that could mean in a negative way for those of us in the community? Whether you're,
Well,
whatever your insurance may be.
part of it is a lot of our money comes from the state, but the state gets a lot of money from the federal government. So part of it is the state's not sure, like they passed a budget, but they know it's quite possible come October or September, once everything's settled in the federal government, they may have to come back. There are threats to our NIH grants. There are threats to reimbursements. We don't, the worst for, how many working groups do we have working on executive orders alone?
There's one for each EO and.
For
then the
every
stuff-
EO, we
stuff
have
committee.
groups working. And the hardest part is, we don't know. That's the whole thing.
Yeah.
You know, so yes, there is no health system you will have come to your meetings who will not tell you they're terrified, will say they're not terrified.
And we're deploying as if it's an emergency. Honestly, that's how we're configuring ourselves in terms of working groups, task force, to start to think about what the impact will be.
And unfortunately, it's not that the current administration cares much about New York. The only good thing is there are upstate Republican members of Congress whose hospitals may be affected by the same things.
Challenging times.
Yes.
Unprecedented.
Anybody else have any questions or Sandy?
I know you told us that you don't have any ideas, but we, of course, in the community are very concerned about what's going to happen on the property where the hospital needs to be. Do you have a timeline for when some of those decisions will be made?
No.
I don't have a timeline, and then, obviously, right now, our fires have really been on executive orders. I know that there's working groups, but I would be totally guessing.
Yeah, there's no, I mean, and we've notified you, we did sell some property on 17th Street, but that's like small stuff. obviously, when we get to the point that we are even gonna market the property, we will alert you. And we understand that you will be asking us a whole bunch of questions and things at that point, but no decisions at this point have been made.
We have some very clear objectives.
I wouldn't expect anything less.
Is the 17th Street sale public? Do we all know who the
Yeah,
purchaser is?
Yeah.
Okay.
Yeah, we sent it to you guys. I sent it to the board.
I think we did contact the people who purchased it.
I think it's something called Joy. I think it's okay, I knew there was a Joy in it or something.
Furniture store.
No, it's, no, I think it's gonna be residential.
Oh, really?
Yeah, no, because they took the Fearman, I
So
think it's the
furniture
Fearman
store.
building is the biggest of the group.
Yeah.
They did.
Oh.
But yeah, but we notified all the elected officials and the community boards when that comes.
Okay, I'll
But-
spoil my reading, sorry.
But when we get to the point that we are made a decision to start marketing it, we will, obviously alert you, and then we will allow you to vent and air what you want to do. We understand that obviously, whereas like a lot of what we do is very important to also board 3 and board 5, the sale of the property really only affects board 6 more than any place else. We get that. We understand.
And I think board 3 as well as our board is really concerned about trying to find hospital care that's south of Belleville. It's quite a change.
But let me say this, and I'm gonna say this, and the way you access 95% of your medical care is not changing. Most of your medical care is you go to the doctor, you go to your appointments, you do everything else. All that, we still have an extremely robust area to serve you. The only difference is, and if you looked at our numbers at the end, there weren't a lot of people in our hospital for medical needs. And the people who need behavioral health needs are being well taken care of at the Rivington. So I understand the emotional aspect of a hospital closing, and I don't think anybody here doesn't get that. But the actual effect to how everybody's treated is gonna be, I think, much less than people anticipated. Because the way, again, thankfully, most people don't go to hospitals, which is a good thing. So,
And again, it's probably the emergency.
right,
It's the most important. And the pandemic is not that far behind us, but we forget that. So a robust emergency room is probably what we're looking for.
well, we do, again, that's part of why Bellevue's getting millions of dollars from us also, to enhance their ability.
Yeah,
I
I'm not sure
understand.
how long it's gonna last.
And what do you think of the idea of like micro hospitals?
I'm gonna echo Dr. Carr, who's an emergency room physician, our CEO, and, in an urban environment, they really probably do more harm than good, right? Because people delay care. And if there's better care that they can get to in a timely manner, they really should go to a tertiary quaternary hospital. If you're in the middle of a very rural area where it's a very long time to a larger hospital or a tertiary quaternary setting, then of course they're better than nothing, right? They can stabilize and do things, but when we see what micro hospitals can do, you really are stuck if you need something more than what they can do, and you've delayed care. We use the one for chest pain all the time. If somebody actually is having a heart attack and they need a cardiac catheterization, but they've gone to a place where they don't offer that, a micro hospital, they need to be transferred. And so that's just delaying care. Now, we have, I always say you didn't blindfold yourself in Manhattan and trip over great medical care, right? We're very fortunate that we have, large health systems just about in every, corner of Manhattan. But in a more rural setting, the micro hospitals do serve a purpose.
And our numbers still do show that Manhattan is overbedded. That there is, if you look at all the hospitals, there is bed capacity, between ours, Presby's, they're.
It's kind of skewed though.
No, but I'm not, Brooklyn and Queens might have a different,
No,
there's
I mean,
different
even
numbers.
within Manhattan, it's skewed, right? Like Upper East Side has way more bed capacity than, let's say, South of 14th Street. So it's skewed geographically in the sense that areas that have a lot of hospital capacity, they're being underutilized, whereas areas that really need the hospital capacity, is essentially a hospital desert.
But I'm gonna go back to a little bit of what I said, and this is when I was born many moons ago, my mother spent 8 days in the hospital. How much time do you spend in the hospital now when you give birth? My father-in-law had hip replacement surgery in 1996 and spent 2 weeks in Beth Israel North or Singer. My wife had hip replacement surgery in 2017 at Mount Sinai West, and she went home that day. So,
Today, you wouldn't even have it in the hospital.
right,
You'd have it in-
but so the whole thing is that hopefully you're not in, I'm not saying that some people may be inconvenienced. I'm very mindful and I'm not, but it's not a long time. All that's changed. You're not in the hospital, even for really serious stuff these days, for heart surgeries. Now, you're getting out of the hospital very quickly. So you may have to travel a little more than you want to, but there are places to take very good care of you and you're not going to be in there that long.
Seems to me a lot that just the community in general needs so much more information about what they can access, what's available. Cause I just think so many people don't know how to even get care.
Well, I
Yeah.
would give you the thought if you wanted to, and we'd be happy to work with you and even work with our competitors and such. Why don't we have a resource fair or something, or a health resource fair in Community Board 6?
So we've been talking about that.
Yeah.
All of our meetings, that's what.
Yeah,
we're
we've talked about having a health fair in.
I wouldn't even say a health fair as much because a health fair gets bogged down with stuff. I would almost say you want to have a health fair aspect to it, but it's almost the idea of a resource fair. So people know when they really have, look, I do a lot of health fairs. We take your blood pressure, we do
No,
your.
I think that's what we meant.
No, I mean, right, yes, okay, I'm saying, okay,
Yeah.
so I'm saying, have a resource fair. I'll help you. I'll help
I
you
think
set
so.
it up. But I mean, but I think if that's what you're looking for, let people know what there is.
I think that's what we meant, right? Because we were saying that people know. that
There's a
community-
question.
We
on-
tried that a couple years ago and the venue that we were going to wouldn't allow third-party vendors. And then we couldn't find another venue, and so we just stopped planning.
But since you're going to help facilitate this with us, I'm sure you have great venues all over the city to help.
Well, it has to be in Community Board 6 though.
Well, there's an
Yeah.
there's an empty building on First Avenue.
Yeah, but yeah, but it's boarded, so I can't really, no, but I'm seriously, if you want to do that, I'm happy to work with you guys to try to help get that off the ground.
Andrea, online, there's a question. Andrea, go ahead.
She's muted still.
Andrew, you should be able to speak.
No, it's.
You're still muted.
She's still muted.
You know,
Thank you. I didn't have the button before. I think even though the major academic centers are spreading out to the suburbs, a tremendous race to do so, I think it's a little misleading and perhaps even disingenuous to look at the population of Manhattan and the number of beds and simply calculate the number of beds per population when we know that many of the patients and the hospitals don't share with the community, you know, the zip codes of origin, so we don't know, but I'm sure there are many patients in the major academic medical centers in Manhattan who come from the suburbs, the tri-state area, all over the East Coast perhaps, and even other countries. So we don't actually know how many beds are utilized by Manhattan and Lower Manhattan residents.
That's not how they calculate beds. Yes, we clearly have people who come from New Jersey, Westchester, Brooklyn and such, but there's still bed capacity, still a bed, an open bed's an open bed. It doesn't matter whether somebody from India is using it, somebody from, New Jersey is using it. It's open beds. It's not telling who's in the bed. It's saying how many beds.
It's only an open bed. It's only an open bed if it's not filled. But if you
Right.
say that, how many beds are available to people in Lower Manhattan, if they're filled by people from other areas, then they're not available.
And I'm contending that they are, we're gonna have to agree to disagree on this one. I'm saying it doesn't matter where the patient's coming from, there is bed capacity in Manhattan. I wouldn't say it if I was in a meeting in Brooklyn, I probably wouldn't say it if I was in Queens, but I can say it in, I can say it in Manhattan.
What is the fill capacity in Mount Sinai Hospital? Normally on average? Like how many people are in your beds,
In the
like
main
percentage wise, main hospital?
It does vary by season. There's in the 900 range.
And how many beds do you have?
A little more than that, you know, when we're under construction, we close beds temporarily, so the daily census and open bed count does vary. It can vary by 50 beds, 60 beds, but it's probably a little over 1,000 beds.
But.
So kind of full.
No, but Morningside has capacity,
Yeah.
West has capacity, we have, we are a system.
Yeah, it's complex, I get
Yeah.
that, but yeah.
And then you start to develop centers of excellence, right? This is what you want, right? And so somebody who lives on the west side isn't gonna have their cardiac cath or their valve replaced at West. They're gonna come to Manhattan, to the hospital on 98th Street, because that's what the center of excellence for heart disease is for those things. So it's, you kind of do wanna, of course you want the bread and butter beds available to people, but the goal is to really have people have the ability to travel to where the best possible care is.
I totally understand the medical world.
Jesus has a question back there.
Oh, sorry, he's not allowed to
You're,
answer.
no, you're.
Go ahead.
Earlier I said it was Joy Bird, it's Joy Land.
Joyland, okay, I knew there was a joy in it.
There's a company that bought seven.
Yeah.
Yeah.
Whiteboard is definitely. a brand.
Okay. yeah. And like I said, I'm happy to work with you on the resource fair. And also, if you have more questions, follow up, we'll come back.
Not a joyful question necessarily, but you're saying this is not a profit center on 14th Street. Is there a concern that the business model may change and say, what are we doing there? So let's get out.
It would have to be really, we were losing so much money at Beth Israel. Even when we were thought of the idea of the 70-bed hospital, we knew that was gonna lose money. The plan was to lose less money.
There's no conversation about
Yeah.
this right now.
Yeah.
Our goal
You
is.
guarantee us so many months minimum?
Oh, something catastrophic would have to happen for this to close. at
Like
this-
the reconciliation bill goes through as it's.
Even that, I don't think, they'd sooner lay me off than close the,
There may be more demand for. quite honestly.
There may be more, I'm just saying, that's not in the plan at all. What I wanted people to understand is, we're not looking at it as a profit center. When we're deeming success, we're not deeming it a financial success. Hopefully we'll lose. Look, if we break even, be a wonderful thing, but losing as little money as we can is probably the goal from the financial aspect.
Thank you.
Thank you.
Thank you.
Thank you.
I mean, when you're ready for your new primary care doc, let us know.
Yeah, it was a fluke. I came across him. I don't know. I get it. He's an amazing, intelligent, smart, grumpy, grumpy doctor.
It's the rain.
The other is always interesting. Otherwise, that's a great venue.
And we also have the
We-
garden.
Moving on.
Thank you very much.
Thank you.
That's right, because I would like, I would like to do that.
What do you want to do there?
The health fair.
Okay.
We're moving
just
on
have to
to
guarantee
What happens
agenda
when
number
it's
2.
You just
Beautiful
have to
weather.
rather, that's
That's
it.
Always the
You
case.
just have to control it.
So moving on to agenda number 2, so we can all get out of
Yeah.
here early, or as early as possible. So discussion on the Support Act that they presented on last time. I'm in favor of writing a resolution in support of it, unless somebody has any objections or want anything to
Support of the
discuss.
support.
Support of the Support Act.
Okay.
Support the Support Act. Anyone
You're
have
for our
any?
support?
Yes.
Yeah. Right idea.
Um, so unless anybody has anything really they wanna add or say, we,
We're not meeting until September.
yeah,
Right?
yeah,
Yeah, and
so,
the September meeting will be the day after full board in September.
okay, so,
I'll also add one other thing in terms of timeline, so the state legislature, for those of you who don't know their timeline, about this time of year is when the state legislature is wrapping up their session for the year.
Okay.
So the next like, bar, like, some special session, which, you know, could happen depending on what happens in DC. It likely won't be until January before legislators come back to Albany.
So then how about this? If it hasn't passed by September, then we'll have a resolution in September, resolution supporting the Support Act in September, but if it's already passed the legislation, then it doesn't really make sense.
They only have
to-
5 more days or something.
Yeah.
Session.
Yeah,
Something
so
like that.
let's watch what happens in Albany and then make a decision from there. Chair's report, I got nothing, wave. So other than that, old and new business, the only thing I have to say to that is, as the new chair, I wanted to meet with each one of you like one-on-one, just to kind of discuss what your priorities are gonna be for the committee. I know what my answer is, but I also don't wanna just, I wanna hear what you have to say as well.
And congratulations for.
Thank you. So, yeah, so over this next 2 months, when we have some time off, I would like to just kind of have that quick chat. Me and Gloria, whatever works, yeah. And Gloria is the new vice chair, so. Yeah. So,
Yeah, I mean, I was just talking, even just our meeting last night, I spent a lot of time working in trauma and I feel like everyone is really feeling traumatized by everything and all the uncertainty and all the things that are going on around
Yeah.
us. And so there might be something to look at in terms of how to support community or do something. And I think the fair, for sure, we just got an
I still
offer. I
feel
don't
we
I
need
think
to
we
do
should ever
research
reject
there.
an offer.
Yeah.
Right?
Especially if they can, especially if they can secure a venue.
Yeah.
Yeah.
So like you
If
said.
Kevin can just ensure that there's no rain, we have a very convenient venue.
No, I can't make that.
So,
And I just wanna say, the fact that they're getting a CT machine, nobody's going to know that. But,
Yeah,
That's the whole
Yeah.
thing.
So it's really important that we try and get the word out.
But there's even places like the National Night Out, there's a lot of people that go through that. Anything was gonna help. I mean, whether it's the CB6 table or if they wanna have one, right? Just making sure people are aware.
Yeah, and, I mean, there are 2 places, it's usually the two parks, the lower park is probably.
One
Because,
per precinct,
pardon me,
one per precinct.
But you're talking about 13th precinct one.
13, yeah, because Bellevue has a table too.
no,
But, I'm sure they wouldn't mind if some of those people went to their.
yeah, I'm sure Bellevue would appreciate that.
Yeah.
Yeah.
So we could reach out and ask them if they could do a table.
Yeah. So.
I thought of that.
Right, so we can work on that over the summer and, other than that, there's nothing to vote on and, anyone else have any older new business? If not, can I get a motion to adjourn?
Motion. Second.
All right, meeting is adjourned at 7:42 PM.
Wow.
For the record.